Have you ever found yourself, stuck in the healthcare system, waiting for what feels like forever, maybe in an ER, or maybe you know someone who struggled to get a hospital bed, even when things weren't crazy busy? It's more than just annoying, right? These delays, they have a real human impact. Well, today we're doing a deep dive into something often overlooked but absolutely critical: hospital bed management. Think of it like this huge, complex puzzle. Lots of moving pieces, and how well those pieces fit together. That directly affects care for, well, all of us. Our guide for this is a really interesting research paper. It's called a Decision Support Simulation Model for Bed Management in Healthcare. Comes from a team at Missouri University of Science and Technology, Fort Lewis College, and they worked with the Veterans Health Administration. And it really digs into how hospitals can use data and some clever modeling to actually run things better.
Yeah, and our mission today really is to unpack how this kind of sophisticated modeling, specifically something called discrete event simulation, can give us a shortcut, a way to understand the operational heart of a hospital. We'll uncover some maybe surprising facts about efficiency, about patient flow, and we'll show you how these really complex problems are being tackled with some innovative solutions. The goal: better patient experience and, crucially, better outcomes.
Okay, so you mentioned the stakes.
Yeah.
Why is managing beds efficiently such a constant?
Well, such a headache for hospitals. I mean, on the surface, it seems simple enough, right? Hospitals have a set number of beds, limited resource.
Exactly. That's the core challenge. It sounds simple, but the consequences of not managing it well are huge. We're talking significant scheduling delays, longer and longer queues for patients waiting for a bed,
Yeah.
patient dissatisfaction too. You get more people just giving up and leaving without being seen.
Yeah. And worse, these prolonged delays in getting care, they can tragically lead to preventable deaths, reduced quality of life. They can even help diseases spread. And just for context, think about this. Back in 2013, healthcare was already over 17% of the US GDP.
Mm.
That's massive. So there's this huge economic and societal need to make these systems run efficiently.
It's incredibly sobering. So is the problem usually that hospitals don't realize the risks, or is it just the sheer complexity of how hospitals operate?
It's often the complexity. Yeah. The challenge usually stems from maybe a lack of a deep understanding of all the internal functions, how different departments connect. It's not just one unit doing its thing in isolation. Everything's linked. A bottleneck here can cause ripples way over there in ways you might not expect.
Okay, so how on earth do you even start to map that out, to predict those ripple effects without, messing things up in the real hospital? This research used something called discrete event simulation, DES. Can you break that down? You said it's like a virtual hospital.
That's a great way to put it, yeah. DES lets you build a computer model, a sort of digital twin of the hospital system. And then
Yeah.
you can test out different ideas, these what-if scenarios, like, what if we change this process? What if we add staff here? And you can do all that without the cost or the risk of trying it out for real first. It's like a safe sandbox to play in.
Makes sense.
And DES is particularly good for healthcare because, well, hospitals are incredibly complex, dynamic systems. There's so much uncertainty, variability, what we call stochastic behavior.
Stochastic, meaning unpredictable.
Pretty much. Like, you can't perfectly predict when patients will arrive, what care they'll need, or if complications will pop up. DES is designed to handle that randomness. It lets you make pretty accurate predictions about outcomes, which is vital before you invest potentially millions in a real-world change. The paper mentions they use specific software, Arena, which uses flowcharts to kind of map out how patients or entities move through the system.
So they built this sophisticated model. Did they actually test it on a real hospital? Or was it more theoretical?
Oh, they absolutely did. And that's what makes this study really compelling. They applied it directly to the Sacramento Veterans Administration Medical Center, the VAMC. It's a real functioning hospital, provides acute care, has beds spread across different units, ICU, a transitional care unit, TCU, and a medical surgical unit, MSU. And just like any hospital, patients get assigned to these units based on how sick they are, their acuity, and what kind of care they need.
Okay, wow. So building this virtual VAMC, that must have required a ton of data, right?
Yeah.
Getting all the details correct.
Oh, absolutely. A massive effort. They gathered 5 years of patient records. We're talking about data for over 23,000 patients.
5 years.
Yeah. They tracked exactly when patients were admitted, when they were discharged, and anytime they were transferred between units. They also tracked transfers specifically for about 1,100 patients over a separate year. All this data let them calculate the really key metrics: average length of stay, how long patients waited, how long it took to turn over a bed between patients, queue lengths for each department, essentially mapping the hospital's operational pulse.
And I noticed in the paper, they didn't just use numbers. They built in rules for how the virtual patients behaved.
Right. That's crucial for realism.
Like, patients only move to a department if a bed is actually free. Otherwise, they wake. In the ED usually.
Exactly.
And scheduled surgeries. They wouldn't even start unless a post-op bed was already assigned. Guarantees a spot.
Correct.
They even included things like bed cleaning time. 2 hours where the bed is out of action.
A necessary delay.
And they used a simplified queue rule, first in, first out, FIFO. They acknowledged real decisions are more complex, but it was a starting point.
Yeah, you have to make some simplifying assumptions in any model. Clinical judgment is hard to perfectly replicate.
And they even had overflow rules, like if the queue on one floor got too long, patients might go to another floor. Or in serious ICU backups, diverted to another hospital entirely.
Yes, those rules reflect real-world pressures and decisions. It adds another layer of realism.
So you build this complex model, feed it tons of data, program in these rules. How do you know if it actually works? If it reflects reality?
Great question. That's the validation step. It's absolutely critical. They compared the model's results, specifically the simulated length of stay, or LOS, with the actual LOS data from the hospital for a full year, 2014. And the key finding was there was no statistical difference between the simulated results and the real-world data.
Wow. So the model was basically mirroring what was actually happening.
Exactly. It means the virtual hospital behaved like the real hospital, statistically speaking, and that gives you confidence. Confidence that when you test those what-if scenarios in the model, the results you get are likely to be reliable predictors of what would happen in reality.
No statistical difference. That sounds pretty definitive. But, in your experience, are there always little things, real-world nuances that even a great simulation might miss?
Oh, absolutely. That's a fair point. Models are powerful, but they are abstractions. They simplify reality to some extent. For instance, this model, based on the data they had, only tracked one transfer between units per patient. In reality, someone might move multiple times.
Okay.
And the bed cleaning time was fixed at 2 hours because they didn't have detailed data to create a statistical distribution for it. Little things like that. But the beauty of these models is they provide a really solid baseline. You can test changes with way more confidence than just, gut feeling or guesswork.
Right. Okay. So the model is built, it's validated. It's like a reliable digital twin.
Yeah.
Now, for the fun part, what happened when they started tweaking things in the simulation? The paper looked at 3 main scenarios, right?
Correct. 3 crucial what-if scenarios. The first one focused on bed turnover time.
Which is? Remind us.
That's the time gap between one patient leaving a bed and the next patient getting into it. And crucially, it includes the cleaning time.
Okay, so the action they simulated was reducing that turnover time from 2 hours down to just 1 hour. Imagine how they might do that in reality. Maybe more cleaning staff or a super streamlined process.
Exactly. And the impact. Get this. Just cutting that 1 hour off the turnover time. It resulted in a statistically significant reduction in patient wait times across the entire hospital system.
Really? Just from that?
Yep. Average waiting time dropped from almost 8 hours, 7.95, down to about 6 hours, 6.10. And the average number of people waiting in queues went down from nearly 3 patients to just over 2. A simple operational change, huge impact.
Okay, wow. Scenario 2.
Scenario 2 looked at reducing the average length of stay LOS. How long patients actually stay in their beds.
And the action was cutting LOS by 10 hours. For patients admitted directly or transferred in, how would a hospital even achieve that in real life?
Well, several ways. Better discharge planning, maybe. Faster doctor rounds to make decisions quicker. Getting tests done faster. Anything that safely moves a patient to the next stage home. Or maybe a lower level of care more efficiently.
Okay. And the impact of reducing LOS by 10 hours.
Even more dramatic. Another statistically significant drop in waits and queues. Average waiting time plummeted from that baseline of nearly 8 hours down to just over 2 hours.
Whoa.
And the average queue size dropped from almost 3 patients down to less than 1.80 patients on average. But here's something really fascinating. The effect on patients being diverted from the ICU. Remember that overflow rule?
Yeah, if the ICU queue got too long, patients had to go elsewhere.
Right. With the baseline model, about 11 patients per year were diverted like that. But just by reducing the average length of stay by 10 hours, that number dropped from 11 down to only 4.
That's huge. That's potentially life-saving, keeping critical patients where they need to be.
Exactly, a direct impact on critical care capacity just by improving flow elsewhere.
Incredible. Okay, so turnover time, length of stay.
Yeah.
What was the third scenario? Adding beds.
Yes, but not just randomly adding beds anywhere. This is where the simulation gets really smart.
Right, because you want to add them where they'll do the most good. Where are the biggest bottlenecks?
Precisely. The model had already identified the departments with the longest waiting times. The third floor TCU, with waits averaging almost 9 hours, and the fourth floor MSU, where waits were over 13 hours on average.
Ouch. 13 hours.
Yeah, so the simulation tested adding beds specifically there. First, they added 4 beds to that third floor TCU, took it from 16 beds up to 20.
And the result?
The average waiting time for that unit just collapsed, from nearly 9 hours down to 0.4 hours, less than half an hour.
Wow.
And the queue went from an average of 1.57 patients waiting down to almost 0.07.
Just by adding 4 beds in the right place.
Exactly. Then they looked at the fourth floor MSU, the one with the 13-hour waits. They added just 2 beds there, from 5 beds up to 7. Average waiting time dropped dramatically, too, from over 13 hours down to about 3.5 hours. And the queue shrunk from 0.37 patients to 0.10.
These numbers, they really paint a picture, don't they? How targeted changes pinpointed by the simulation can have these massive ripple effects. It's not just guesswork.
Not at all. It demonstrates the power of understanding the system dynamics.
So taking a step back from this specific hospital, the VAMC, what does this research mean for healthcare more broadly? What are the big takeaways?
Well, I think the biggest implication is just how powerful and applicable this simulation approach is for healthcare operations. It gives managers a robust, evidence-based way to model how their hospital actually works. It empowers them to test potential changes like new staffing models, process improvements, adding resources, and actually quantify the likely impact.
Without the risk and cost of a real-world trial and error.
Exactly. It enables proactive, data-driven planning instead of just reactive fixes. And importantly, the basic structure of this model is generalizable. It could be adapted and applied to pretty much any hospital, provided they have similar kinds of data available. So the potential impact is really widespread.
Did the researchers translate these findings into concrete advice for hospitals, like actual steps they could take?
They did. Based on their findings, they offered some very practical recommendations. Things like implementing really clear, fast communication between discharge staff and cleaning crews to cut down that bed turnover time we talked about.
Makes sense.
Also, frequently reviewing patient status and their required level of care. That helps reduce unnecessary length of stay and can prevent those queues building up that lead to transfers or diversions.
So being more proactive about moving patients along when it's safe.
Precisely. And finally, just regularly looking at and updating the hospital's own scheduling and discharge policies. Are they still optimal? Are they creating unintended bottlenecks?
These sound like actionable things managers could actually implement.
They are. They bridge the gap between the simulation findings and real-world operations.
Now, you mentioned earlier that no model is perfect. This study obviously advanced things, but what were some of its limitations, and where could future research go from here?
Right. Acknowledging limitations is key. As we touched on, the model simplification, like only allowing one patient transfer, was based on data constraints. Real life can be messier. And the fixed bed cleaning time, ideally, you'd have data to model that variability too.
So future research could build more complex models.
Definitely. Future models could incorporate other critical resources that impact flow. Think about nurses, doctors, specialists, even equipment availability. That would give an even richer, more accurate picture. There's also huge potential to integrate optimization algorithms directly into these simulations. So the model wouldn't just predict outcomes, it could actually suggest the best way to allocate resources or schedule activities to meet certain goals, like minimizing wait times or costs.
That sounds powerful.
Very. And looking ahead, you could apply the same simulation approach not just hospital-wide, but zoom in on specific units like a busy wound care clinic or a neurology ward to optimize their unique flows. Or even use simulation in the design phase of new hospitals or clinics to ensure optimal layout and flow for both patients and staff right from the blueprint stage.
Fascinating. It really opens your eyes, doesn't it? To think how something seemingly small, like shaving an hour off bed cleaning or adding just a couple of beds in the right spot, can ripple through the whole system. It can drastically cut down how long patients wait, improve access to critical care. It's kind of amazing.
It really is.
That hidden hour of cleaning, it's almost as vital as the surgeon's skill when it comes to getting care to the next person waiting. It's like a silent hero of hospital efficiency. Makes you wonder, doesn't it? What other hidden efficiencies like that might be lurking in all the complex systems around us? Not just hospitals, but, anywhere. Efficiencies just waiting for some smart data analysis and modeling to bring them to light.